And we have with us today our resident epidemiologist and infectious disease expert, Fred Brown. Fred, we only have 15 minutes today, so we got to keep it real tight. What's the latest in terms of the pandemic?
Well, of course, the big announcement yesterday was with President Trump. I almost said Dr. Trump, with the expansion, the emergency use authorization for plasma therapy. And you remember that was one of the therapies that I thought early on was going to be helpful. But I'm not sure about this particular use of the emergency use authorization. I'm a little bit concerned about it for some reasons. We can certainly go into that if you like.
Yeah, let's go into that because I'm sure that's on everyone's mind, and certainly during the Republican convention this week, I'm sure they'll be talking about that. So give us your perspective on this.
Yeah, so I mean, it is not a knockout punch. What it means is that if you are infected with COVID and you're hospitalized and having challenges, what they've done is they've used data from the Mayo Clinic. They had about 37,000 total patients across 2,800 different sites. And what they found was that if you had a significant IgG or significant component of dose of plasma therapy, then your survival rates would be improved by about 2.5 to 3%. So it's not it goes from your death rate goes from 8.5%, so from 11.2% to 8.5% with significant amounts of plasma therapy. And there is a dose response that's indicative of some help. Unfortunately, what was quoted during the press release was a 35% reduction in overall death rate, and that's not right. The overall death rate reduction is only 2%. The relative reduction across two populations, both treated with plasma therapy, is about 35%. But don't forget, we didn't try it compared to nothing. And what's interesting is we have results from clinical trials in both the Netherlands and China that indicate that when you compare it to doing nothing, there is no statistical significance, sadly, and there is some risk of course, infection and other things as a result of going through a transfusion with using a convalescent plasma. I think, though, that if we do enough studies and we understand the dosing, that we will find some positive benefit. But I'm concerned about a couple things. I'm a drug developer, and what happens whenever you whenever you say to people, it's now available commercially, but by the way, there's also a chance to take part in this clinical trial, and you've got a 50% chance of either getting the drug or not getting the drug. People are going to say, give me the drug, forget the clinical trial. So the result of that is that our chances of actually completing a lot of the trials that we have underway get significantly reduced. And there are a whole host of trials underway. There's probably 15, 20 trials that are properly and statistically and methodologically correct in order to actually determine whether this is the case or not. Right now, we're just using anecdotal evidence of people saying that guy looks pretty sick, we better give him some drug, and then afterwards saying, oh, we had some success. That's not a prospective, controlled, randomized clinical trial which had a placebo and control group. That is what we really look for to make the standard work. And so the result of that is that if you look, as doctors, what you do is you go to the Infectious Disease Society of America and you look at their treatment protocols, and you go to the NIH and look at their treatment protocols, and neither of those societies which doctors actually follow have changed their treatment protocol recommendations. And that's because we just don't have the evidence right now that we would normally ask as physicians to have in order to treat people with this kind of a therapy.
One thing I wanted to ask you about, Fred, in the scary headline department, is we learned last night from the New York Times, authorities in Hong Kong have reported their first case of reinfection. Somebody had it before, had the antibodies, and then got it again. So what does that tell us?
Yeah, so it is possible. It is possible, and that it is reinfection, and we're still struggling with it. We saw that initially in Korea, where they had a significant number of cases called quote unquote reinfected. We think a lot of those were just sequestered and kind of disease that was hiding away in various locations that we hadn't, tested and were sheltered from a blood test or a saliva test. And that happens often. So it comes back. Well, we're finding that this is a very pernicious disease and that you can get, low levels of titer for a long time that are undetectable and then pop up, 2-3 months later. So we're not sure if it's reinfection. That's really disappointing, because it means that antibody levels of people who have been infected aren't sufficient to prevent you from getting the disease again. And that's what we're really looking for in effective vaccines. So that would suggest that a vaccine might not be fully effective and that it might not be have a very long duration. Right now, our best guess is that you've got some protection for 3 months. That's as long as you've been able to test so far, because the antibody is still novel. If we're like MERS and SARS, then you could get as much as 2 to 4 years of protection. That's what we're really hoping for with a vaccine. But those kinds of results indicate that's doubtful for this particular, for COVID-19, sadly.
So it keeps getting back to the vaccine. Is there any vaccine update you can give us? I know it's only been a week, but I mean, has anything changed?
Oh, lots. So believe it or not, last time, 2 weeks ago, when the last time it was reported, and you're watching the enrollment rates of this vaccine go up, right? And 2 weeks ago, when we talked about this last time, there were about 4,500 people enrolled in the 30,000 person study for Moderna, and about 2,750, as I recall, enrolled in Pfizer. Believe it or not, collectively, Moderna and Pfizer now have enrolled 25,000 patients.
Wow.
So it's gone up 20,000 patients in 2 weeks. That's remarkable. I do a lot of work in enrollment management for clinical trials. I mean, to get 20,000 in 2 weeks that's just unheard of. It's a huge. They're out there, and people are eager to volunteer, and they're recruiting heavily, which is great.
Good. And clearly, until we do get an effective vaccine, whatever that might be, whatever the new normal is going to be, we don't even know that. I mean, do you suspect, even if we get a vaccine, that we're never going to go back to the way everything was before the pandemic? Do you think there'll still be changes?
Oh yeah, I think sadly, I think what's going to happen is that our initial vaccines will be partially effective, and we'll have some therapies that are partially effective. But we're going to have to continue to monitor the disease and manage the disease, patient by patient, if we're lucky. If not, we're doing it on a population basis right now, but patient by patient, probably for at least 10 years. I don't see us going back to a quote unquote normalcy with that until we get a fully sanitizing vaccine or a significant change in the virulence of the disease. That's what killed off, quote unquote, killed off Spanish flu, is that it mutated enough that it became kind of part of the endemic flu problem, not something special. And if that happens with COVID, if there's something that happens with the nature of the virus itself that we don't really control, frankly, then that could cause us to go back to normal. More likely, we will have a sanitizing vaccine. My sense is that's at least 10 years away.
Wow.
Yeah, so it's a ways. We have a ways to go, and I think that means a lot of testing, a lot more testing. Probably what will happen is we'll test ourselves every day. Self-administered, very rapid, very inexpensive, and those tests will be coming out in the next 3 to 5 months, and everybody should, be on the lookout for them and start trying them out. Because
that's the saliva test you're talking about that I heard about this week.
That's right, the saliva test. There's one in Boston, there's one in Yale, there's one in Stanford. They're all starting to look relatively interesting. What we're finding is that we need to have, in order to do this what's happened is our society just doesn't lend itself well to centralized clinical testing and all the transport and the slow turnaround times. And the high cost of our current testing infrastructure. So we have to look for disruptive technologies, and the disruptive technologies that are out there include, breathing technologies coming out of Israel called NA nasal, as I recall. There's a group. There's the E group in Boston that's using strips of silver coated paper that changes quite sensitively to drug. There's a special what they call LISPR technology that's coming out of Stanford that's actually probably going to be the most likely candidate for in a longer term scenario. And then there are instances where you can use existing technology with very, very fast turnarounds. That's what's happening at University of Illinois. They've got a full setup of several $1 million PCR machines at University of Illinois that that are able to test 10,000 people a day. You need three of them, running 24 hours, and that costs $10 a test. And you got to be right on site with that technology. What we need to have is something that's instant, self-administered, that's quite accurate to the PCR level if possible, very fast. So instant means less than 10 minutes, I would say, so those and cheap. We have to get kind of below a dollar.
Yeah, that. Yeah, right.
Oh, that part of it. Yeah. So that right now, if you look at all the tests, nothing is available right now that we have that are all three of those things. So you got all five of those fit all those five of those criteria. So we're going to have to actually look for new ways of testing, and those systems are coming out, as I said, in 3 to 6 months. And
then finally, I will realize we ran out of time. I know one of the things we were going to talk about, and now I've got to put that link up, is how to properly wash your hands.
Right.
I don't know if you have that link available. You can show us.
I do. I think I've got it. Let me take a look if I can find it.
If nothing else, that's what we can do right now is wash our hands properly, right?
It's one of the tricks. So
well, you basically have to wash like you're prepping for surgery, right? You have to wash like the doctors do before surgery.
Well, there are two levels of washing. There are two levels. Can you see my screen?
Yeah.
Yes.
There are two levels of washing. One is clean and one is surgical. Surgical actually means, septic level of capability. That's a 2-minute wash. It's up your sleeves and everything. We're just talking about clean levels of hand washing, which you want to, first you wet your hands with water so that you get then you put your soap on it. It should be about a teaspoon of soap generally. You can look at the instructions. That's about right. It's better probably for liquid soap than normal soap. It doesn't really matter. It doesn't really matter if it's antibiotic or not either, as it turns out. Everything kills this virus pretty easily. You want to rub your hands together around the palm, as it shows, right? Then you want to get the backs of your fingers in between your fingers. Then you want to scrub your palms. And you want to get your thumb, and you want to go down your wrists, because everything that's exposed is exposed to droplets. Then you want to rinse your hands with water. And that's really important, because what the soap does, hydrophilic and hydrophobic interactions, is it pulls the virus away from the oils in your skin with a lot of rinsing off. Rinse off for, everyone says 20 seconds, do it for 30 seconds. If you don't have any soap, then antiseptic is okay. The antiseptic cleanser and alcohol level should be above 70%. It's not the same as hand washing. Hand washing is better. When you dry your hands, use a disposable paper towel. Don't that's not exposed to the water and that you can't sneeze on. And then use that same towel to turn off the water, open the garbage can, put it in, and after you've opened the door to exit the bathroom. And you should probably be doing this 5 times a day or so if you're at an office, and do it every time you've touched something that's a surface that's frequently touched, so high touch surfaces, after you've shaken somebody's hand, after you sneezed or coughed yourself, and certainly after you go to the bathroom. That's sort of the way to do it. And what you'll find is that what people forget, the biggest areas of forgetfulness are the palms, inside your palms, tips of your fingers, and around your thumb are areas, and in between your fingers are the ones that people forget. Usually what this does is it'll reduce the possibility of infection by about 23 to 48%, so good reduction. Don't forget, kind of this touching, you touch your face 15, 16 times an hour. Try to reduce that if you can by using something that's perfumed. It reminds you, I've got something close to my face again. Try to use a soap that has some humectants and some emollients in it. Humectants are things like glycerin, honey, and those kinds of things. Emollients are things like aloe. Those replace the water after, because if you have high alcohol content, reducing the oils in your skin cause dryness, especially if you're washing 5 times a day. So those are some of the hints I've got for you.
All right, and we're going to post this link when we put Fred's video up online. We'll have the link there too, so you can take a look at it, make sure you're doing it properly.
Yep, this is the WHO and CDC official diagrams. It's up on all the labs, so that's what we use.
All right, and that's Fred Brown, our epidemiologist. He's on with us every week, and updates us, and hopefully doesn't scare us too much. But this is really, I wouldn't say a scary time, but it's a very cautious time, right?
It is, and I added that to the mask stuff. If you touch your face mask, that's where all the droplets are. Wash your hands afterwards. If you've taken off your mask properly, take it off from the sides. One last reminder. So and you'll kill off about, with an average hand washing, you'll kill off about 60% of the germs. If you do it this way, you'll kill off 99% of the germs, especially with a 30-second rinse.
Okay.
Traditional four-year students love Lawrence Technological University's thriving campus life. But LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.